Moving on to lower GI and some abdomen review. So make sure you go back through and review your abdomen chapters and upper GI chapters as well, all right? So review your cavities, okay, your abdominal cavity, your pelvic cavity. I want you to review all of this anatomy for me, okay? And pelvic anatomy, what it contains. Review your quadrants, what's in each quadrant, right? We're taking it back probably to first semester here, okay? The regions, what is in each region. Landmarks, review those landmarks. These are going to be on your boards, guys, so make sure you know your landmarks, okay? Make yourself a little cheat sheet of those. We should know all of these right now. Go back to digestive tract, all right? So what are your accessory organs? What do? They aid in the process of ingestion, digestion, absorption. So glands, liver, gallbladder, pancreas, and spleen. What does your saliva do? What does the liver secrete? Gallbladder stores bile, all of that stuff. I want you to review all of that, okay? Break out that A&P book or your chapter on upper GI, okay? Small and large intestine. Know those, okay? What the name here, alimentary canal, I always mess that one up. So go back to those terms. Okay, these are basic of your digestive system functions. What does your small intestine do? Duodenum, jejunum, and then the large intestine. Basically, the major function of the large intestine is to absorb water and then transmit the useless waste material from the body. Small intestine. So know this term, this VILLI, okay? It lines the walls of the small intestine and absorbs nutrients. Chime. What does it do? What's its role? Okay. Large intestine. What is its role? Know the parts. Okay. Parts in order. Basic functions here for large intestine. Okay. Anatomy. We're taking this back. Okay. Parts of your large intestine here, this area, this cecum part here, is the widest. It's likely site for perforation. And then over here, past the sigmoid colon, entering into the rectum, narrowest. This is your most likely site for obstruction. So if you're looking for a perforation on a patient, it's over here early on. Obstruction tends to be further down, right? Because it's the smaller 4 cms. Okay. Large intestine is about 5 feet in length. All right. Takes a while to get through. Rectum anatomy, cecum, terminal ileum, that TI that we do, right, in fluoro. We have that one as well. Large intestine. So 3 differences between large and small intestine. The internal diameter. The large intestine has haustra instead of the villi from the small. Its major function, absorb water. Write that down. And responsible for the synthesis and absorption of vitamins B and K and amino acids. All right, so some clinical indications for having a barium enema will be colitis, could be ulcerative, diverticulosis, diverticulitis. Make sure you research those 2 terms because they mean different things, and those will be on your boards, probably most likely, okay? Neoplasms. The most often one we see most often in BE is the apple core, or they might call it a napkin ring lesion right here. See, it kind of looks like an apple core here. Volvulus. What does volvulus mean? Go back to that. It can lead to necrosis of the intestines, intussusception, that telescoping into itself, right? Or appendicitis. So there's some patient prep for a patient for barium enema. They want to have a light evening meal prior to the exam. They're going to have a bowel cleansing, cathartic. So they're going to be up most of the night trying to clean their bowel. Most of the time they're not super excited about it and will complain to you about it the morning when they come in. But that's what you want. You want a clean bowel, right? Before we put some contrast in there and try and find out what's going on. So NPO after midnight. 8 hours minimum, similar to an upper GI, right? No gum chewing, no smoking, and then they take an enema the morning of exam. What's a cathartic? It's a substance that produces frequent soft or liquid bowel movements. So they will be going to the bathroom a lot before they come in. There's two types. This irritant is rarely used, and then a saline is more common. But there are some contraindications to cathartics. So if there's bleeding, severe diarrhea, if there's an obstruction, obviously you don't want to give them something that's going to then make the obstruction worse, or inflammatory lesions. So some of your patients will not have any prep if they have contraindications to them. There's some room prep. So you're going to lay your table down, have a pillow out, depending on whether I am doing a air contrast or non-air contrast. I keep my footboard on. I don't tend to put a mattress down if I'm going to do an air contrast, because your table's going to stand up and the mattress will fall off sometimes onto the patient. So be aware of that. But you're going to want to have some cassettes available if you're working with a CR equipment. If you're working with DR, obviously you just need the DR cassette. But a grid holder, just in case you need to do cross-table work or decubitus work. IV pole, obviously, to hang your barium enema bag. Clamps, have extra clamps available. Contrast media prepared. I try and have this prepared before the patient goes in. I also don't leave this hanging for my patient to walk into the room to see. That's a little alarming. Okay, so I tend to cover that, or I lay it flat down on the table underneath a towel or something. Have extra towels and linen available. Be ready for worst case scenarios, and some chucks. I would maybe add to this list one of the Barbie pools, those plastic rings that you can blow up with the oxygen. Don't blow it up by mouth. There's an oxygen on your wall that you can easily blow it up, okay? Don't pass out from blowing up a Barbie pool. So some contrast media for barium. So it's a single-use closed system kit. There's two types. There's one with a blue air pump on it, and then this one is obviously a single contrast. But I tend to do room temperature water and not cold. It's a colloidal suspension, so you have to really mix well before you use. Sometimes these have a pre-mixed powder in it that you have to mix. I think at our clinical site, you have to mix the barium first and then pour it in, right? Because these were out of stock at the moment, but depending on where you are or what we have in stock, it's you want to mix it really well. Glucagon, we do not use at our clinical site, but it is in your textbook as an option. If there's severe spasms on the patient, the doctor can give them glucagon to help with the spasms, and topical anesthetic may be added to contrast media. I've never seen that done, but it is a possibility. Enema tips. We have lots of options. The plastic disposable tip that comes in the packet, I never use. I always throw that away. I've never actually seen it used. This is the tip that we have here. It has a balloon on it. This one with the blue tubing coming out is your air one. So this is for inflating a balloon, pumping it up, inflated, uninflated, and these are pediatric tips. They have no balloon. Sometimes we use these on adults that have had previous surgeries or concerns with rectal areas, so they will do no balloon on some of those patients. So they may ask you for a pediatric tip, depending on size or straight or bent. Okay, I always test my balloon prior to placing it in the patient, just to make sure it works. So watch for that. Oh, I jumped ahead of myself. So make sure your balloon works. You're going to get this balloon inflator, connect it here, right up in the area here. It's one of the hardest things to connect. Why they can't make that easier, I don't know. Someone should do that and make millions. But you're going to connect it here and then just give it a pump. This orange piece is your lock, so you're going to lock that in place. Your radiologist may ask you to do a double inflation. So if that happens and the patient is having trouble holding it in, what you're going to do is put a clamp on the tubing here, unlock your balloon inflator, reinflate, connect it back up, release the clamp, give this balloon inflator a second pump. This is going to double up the size of the balloon to help them keep it in. This blue pump here is for when you do a BE with air and they're going to introduce air. That's what they use to pump the air in. Sims position. So we use Sims position for placing an enema tip. So they're gonna, I'd start them lateral, but then drop that top leg forward, bend that leg up. All right. I always go make sure that my radiologist is around prior to tipping my patient. I do not place the tip and then go searching for my radiologist. If they're in the cafeteria getting lunch, your patient has to sit there till they get back. If they're doing an arthrogram in the other room, they have to wait for that radiologist to be available. I always go look first and say, okay to tip, you're going to stay right here. They say yes, I go, I tip, I come out my door, I say, hey, I'm ready, they come right in. I just think if this were me or my family member, I wouldn't want them to have this tip in for, longer than needed. So make sure they're around and that you have someone. So Sims position, make sure you know that position for enema tipping. Enema tip insertion, you want to communicate with the patient. Always wear gloves. Drain air from the enema tubing and lubricate the enema tip. I always tell them it's going to be a cold jelly. Have them take some deep breaths in, blow it out. And you're going to place that tip in their rectum. And I always just let them know, you're going to feel my hands before I touch them. I try and keep them as covered as possible. And once the tip is in place, I always cover them up when I go grab the radiologist. The enema tip inserted into the rectum, no more than 4 inches for a colon examination. I would say just never force the enema tip. If you are trying to place an enema tip and you're getting some resistance, I always ask the radiologist to step in the room with me. We maybe need to fluoro to make sure there's not something there, or maybe there's some sort of obstruction and we need a smaller tip. So if you're getting some resistance, I say hold off. We need to get someone else in here. But your initial insertion is toward the umbilicus, so it's kind of forward here, right? And then your placement is going to be slightly anterior and then superior. So going to kind of kick around and up. Okay. The enema preparation, once your tip is in place, you connect it to the bag if it's not already connected. And then you're going to raise your bag. The max enema bag height above the table is 24 inches. This tends to be a board review question as well. So write that down, 24 inches, meaning this can't be hung on the ceiling. All right. I want you guys to hold on to this tubing, control it. Do not just let it ride when the radiologist tells you to put that barium on. That's going to hit their colon. It tends to cause some spasming. Nice and easy, slow and steady. Keep your hand on it, on and off, quick on and off, and always follow the radiologist lead. They say contrast on, I say contrast on. They say contrast off, I say contrast off. Be in communication with the radiologist. Watch the screen, see where it's going. Don't let it flow too fast. If you get too much contrast in there, then it's sometimes a little bit difficult, especially for that air enema. You don't want too much contrast in. So slow and steady. You got 2 options, usually a single contrast or a double contrast. The single contrast enema can be barium, or it will be a water soluble if there's a question of perforation, or if the patient is severely backed up or something like that and it's a clean out enema, it'll be water soluble. Double contrast, double means air. So they're going to use barium and air. A thicker barium is used for that. It's not the same thin barium as the single contrast. So double has air, single, no air. All right, I'll meet you back here for part 2.